Next week, Rich Belitsky, our own Richard Belitsky, is going to be giving grand rounds on the Yale Medical School curriculum. The following week, the 19th of May, Marcella Nunez-Smith is going to present on precision medicine and the future of race and ethnicity in biomedical research. That should be a really interesting presentation. And then I'm hopeful that the following presentation is interesting, which is the State of the Department address, which I'll be presenting on the 26th. Just a reminder that the state of Connecticut is moving forward in their budget discussions, and it seems like every week we discover that the Connecticut budget is even more dire than the last unspeakably dire prediction. So it's particularly important, if you care about the Connecticut Mental Health Center research mission, that you have communicated that to your legislators, particularly the leaders now of the majority leader, the Speaker of the House, Senator Looney and Fasano. Those are critical people to reach out to. If we get that group in our corner, then there's a chance that the research infrastructure of CMHC will survive for another year, and we would very much like that to happen. Okay, so at this point, it's my tremendous pleasure to have the opportunity to present the Arvid Carlson Pioneer Award to George Agajanian. This is an award, the highest award presented by the Collegium International Neuropsychopharmacologium, or the International College of Neuropsychopharmacology, which is the oldest translational neuroscience organization in the world and the only global organization of its kind. And George received this Pioneer Award, received the notice that he was honored with this award last year, but was not able to attend the meeting to receive it in person. So I pretended I was George Agajanian, and I collected his prize and thanked everyone on their behalf for acknowledging my major contributions to neuroscience. But George truly, in the deepest and most profound meaning, is a pioneer of neuroscience. His groundbreaking studies of nearly every chemical system in the brain, using biochemical, cellular, physiological techniques, and then combining them in the last phase of his career using multifocal in vivo imaging at the subcellular level in the brain, is just a remarkable path of trailblazing. In no small part, I'm here at Yale because of George's pioneering study where he discovered that areas in the locus ceruleus of the brain were inhibited by opiates, hyperactive during withdrawal, and could be suppressed by the stimulation of a noradrenergic receptor with a drug called clonidine. And that led to the development of clonidine as a treatment for opiate dependence. But from a paradigmatic point of view, it was the first time, and maybe the only time so far, that a treatment was developed out of a mechanistic understanding of brain function in psychiatry. All the other treatments that were developed in psychiatry were lucky accidents, and including in some ways the ketamine discovery. So it's my tremendous pleasure to invite George up to the stage to receive this beautiful Arvid Carlson medal. We're going to get your picture taken.
Okay. very much, and I really appreciate this award, because I knew Arvid Carlson very well over the years. As you know, he was a neuropharmacologist in Sweden. In the latter part of his career at the Karolinska, and much of the work that he did, the early work promoting the mapping of monoaminergic pathways in the brain, stimulated me to do my work. So I feel this is a most appropriate honoring of him as well.
Thank you. I will now. Oh yeah, grand rounds.
Yeah.
I'll now introduce Dr. Carolyn Missouri to introduce our session today.
Thank you, John. Good morning. Welcome to the Grand Rounds that's sponsored by the Division of Women's Behavioral Health within the Department of Psychiatry. As the director of the division, it's a pleasure for me to have the opportunity to invite leaders in the field to come and talk with us about outstanding research and outstanding work that they've done over the course of time. And it's a pleasure to have people here not only from the Department of Psychiatry, but also from psychology and other key departments from across the university. It's terrific to see you all. I do want to mention that what the division really is dedicated to is bringing investigators together from different places like psychology, like medicine, like neurology, like neurobiology, neuroscience, other areas, to study women's health and also to study sex and gender differences in health and disease, because as you probably all know, this has been dramatically understudied historically, and we're really only at the beginning of a long road to find out what we need to know to treat people appropriately, and not only in mental health, but also in addictions and other medical disorders. And so one of the great things about being the head of a division is, as I said, you have the opportunity to invite outstanding leaders in the field. And so it's a pleasure today to introduce our Grand Round speaker, who is Dr. Connie Hammen. And she is, of course, an outstanding and highly accomplished researcher in the field of depression. Connie received her bachelor's degree from Stanford University in psychology with great distinction, and with honors in psychology and as a Phi Beta Kappa. She then went on to the University of Wisconsin-Madison, where she got a master's degree and her PhD. She also did an NIMH predoctoral internship there, as many of us did here at Yale. Then Connie went on to join the UCLA Department of Psychology in the 1970s and was only the second woman at the time to join the faculty of the department. Currently, she's an emerita professor there at UCLA and distinguished research professor in psychology and psychiatry and biobehavioral sciences. So what we usually talk about at this juncture is people's publications, their honors, their awards. Well, Connie certainly has received many honors and awards over the course of her career from the American Psychological Association, the American Academy of Child and Adolescent Psychiatry, the British Medical Association, in recognition of her Handbook of Depression that she wrote with Ian Gottlieb and now has 3 editions. So it's been a success and been asked to come back and repeat. She also has been very active in a whole variety of ways, nationally and internationally. Study sections, for example, at NIH, where Connie and I first met in the 90s, as we reminisced yesterday, and on the editorial board of numerous prestigious journals. But the more important issue, I think, for me and for many of us, beyond all the accolades, is really the quality of her work. And I'd like to describe just a few things that she's done. The focus of her career really has been on studying the interrelationships between depression and stress and health behaviors and health outcomes. And she's really recognized worldwide for her theoretical contributions in this regard, as well as empirical investigations on stress and depression. as well as for longitudinal studies in that regard, and really was one of the first people to begin to look at intergenerational depression. Her empirical contributions have demonstrated, very importantly, the transactional influence of stressful life events and experiences on depressive onset and recurrence, and her theoretical contributions have provided a conceptual framework both for herself but also for others in the field to move the field forward. When I started studying stress in the early 90s, many people told me that, well, stress was probably bad for you, but it certainly would not cause a clinical syndrome. Of course, now today, thanks to work in neurobiology from people like Ron Duman and certainly people like Connie and others, we now know that certainly stress is an important factor in disease of all kinds. In many ways, then, Connie has been ahead of the curve. In 1990, she published the first contemporary longitudinal study on the mental health of children of women with bipolar or unipolar disorders. And soon after, she published this very seminal paper that was related to this issue of the transactional nature of stress, in that she talked about the generation of stress in the course of having a disorder and how that affected outcomes. And at that time, that was a new concept as well. Early on, she investigated stressors in the context of Aaron Beck's cognitive model of schemas to understand the personal effects of life events. And these types of extremely important contributions have continued as she's explored acute and chronic stress in the prediction of major depression in women, brain biology changes associated with early stress, and later depression. Her most recent work includes a longitudinal study conducted in collaboration with researchers from Emory University and the University of Queensland, which is a 10-plus year community-based study of the offspring of mothers with depression. And it has a particular focus on intergenerational patterns, as well as mechanisms of depression, stress processes, and family functioning, gender differences, as well as, very importantly, gene by environment interactions. So, as I said at the top of the introduction, most notably to me, beyond her specific achievements and contributions, is the quality of her work and the impact of her findings, as well as the commitment that she's shown in informing our view of depression, which is the single greatest cause of disability for women worldwide. So I'm thrilled to have her here today with me, and it's a pleasure to have this wonderful researcher and colleague talk to us about depression and stress, old issues and new questions. Connie?
Thank you. Well, I want to thank Carolyn and the Division of Women's Health, and thank you all for coming today. It's a pleasure to be here and see old friends and make new friends. I'm going to start by giving a little bit of a historical overview, because I'm really old enough to be able to do that. I'm going to be talking about work that I first started as a student and has continued pretty much continuously since then. But I think it's important to see what changes have occurred in the field of depression, and kind of where are we now as a context for figuring out where do we go. Obviously, we had diagnostic problems until DSM-3 came along. Reliable diagnoses got in the way of distinguishing among bipolar and unipolar depression, between severe mental illness of different kinds, including schizophrenia. We had no particularly effective treatments. We had treatments, but they often had side effects, or in psychotherapy there wasn't anything, because people didn't generally like to work with depressed people because they complained a lot. If therapists were practicing, they were generally informed by a Freudian approach, in which depression was not really the problem, that was just a symptom of the real problem. And it was largely considered to be a disorder of middle-aged women. And you certainly found a number of people who were oriented toward a disease model of depression, in which biological and genetic factors were the cause of depression. but it might have been speculated that there was a different form of depression that was reactive to stress. But nowadays, of course, we have a much better diagnostic system, although it has not solved our problems. As you well know, we're still struggling to find valid and useful diagnostic systems or classification systems that help us to be more precise in our findings. And we now view depression as a highly treatable disorder. Unfortunately, however, we continue to recognize how difficult it is to treat to the point that people are free of recurrences or free of chronic conditions or chronic symptomatology. There's a strong emphasis on genetic and neural and stress risk factors today, more than ever before. And we recognize that depression affects all ages, even children. We discovered depression in children only a few decades ago. But I think we're coming to realize, at least my own hypothesis is that it's adolescent depression that's really the prototype for what we understand as adult depression. And so that's where I believe where the action is. Not all depressed adolescents continue to be depressed later in life, but a good many of them do, and it starts in adolescence. And of course, we recognize now that depression is really a big deal. It really affects huge numbers of the population across all cultures, across all nations, and particularly women. So it continues to be an enormous challenge, addressing all of these issues in their new and different forms. Now, all of you know what the experience of depression is in terms of diagnostic criteria and so forth, so I'm not going to really talk about that. But you know that it affects engagement in life, in relationships, in work, and so forth. It needs to be emphasized how debilitating depression is. And I'm going to talk a lot about the debilitating effect of depression, not only on the individual, but on other people in the worlds of depressed people. And it's highly misunderstood. It continues to be something that people don't understand in themselves, and other people around them often don't understand, think it's a controllable disorder, a disorder of a weakness of will and so forth. But it's really very misunderstood, and so we continue to be challenged by making sure that people have good information about what it really is and what the big deal is. Now, earlier in my career, you could kind of choose among three main models. There was the disease model, the chemical imbalance model with genetic contributions, the psychodynamic personality kind of approach that I mentioned a moment ago, or the emerging influence of the cognitive models of depression, viewing depression as basically a disorder of thinking. But I'd say that nowadays what's changed is that we don't have to choose. In fact, what we need to do is to not choose, and we need to think of an integrative approach. I call it an emotional, cognitive, biological, behavioral, maladaptive stress response approach to depression. And I think that's really what people are struggling with today, is to put together the pieces and the means by which to integrate those concepts. But across the many different perspectives on how you approach depression, stress is a concept that emerges as a core construct in depression, a core player, shall we say, in depression. And obviously there's an enormous amount of interest these days in the neurobiology, neuroendocrinology of stress. But in my career, I've always, and I think these questions of how stress gets under the skin are vitally important and they're very interesting. But I've always been interested in what goes on in people's lives, what's going on in the environment. And so what I'm going to talk about today is really about my work that has looked at that aspect of depression and stress. Now, as you know, stress triggers depression, but the idea is that most stress is not followed by depression. So why do some people get depressed in the face of stress and other people don't? And much of the research over the last, say 20 or 30 years has been on the diatheses, on the moderators and mediators, the risk factors for why some people are going to get depressed in the face of stress. There are the demographic risk factors, and these, of course, are gender, sex, women, younger ages, adolescence and young adulthood, low SES, and other kinds of debilitating environmental situations. Clinical factors such as having a personal history of past depression, having a parent with depression, negative cognitions, dysfunctional information processing. A number of people have studied risk factors in those areas. Or maladaptive coping, ruminative style, something that's emerged fairly recently as a predictor of depression, risk for depression. And then traits and dispositions, neuroticism, low positive affectivity, and so forth. So today I'm not going to particularly talk about moderators and mediators, but I'm going to talk about risk factors that I have studied or that have been supported in my research in particular. Being female, having a depressed parent, particularly a depressed mother, and I'll talk later about our research on children at risk. Certainly stressful experiences, and I'll talk a little bit about several types of stressful experiences that are a big part of risk for depression for some people. And then I'm going to talk about stress generation and stress sensitivity and stress continuity. And a theme that emerges from almost all of these is interpersonal difficulties as risk factors for depression. So let me go ahead and elaborate on these topics. Now, the general operating model is that stress experiences trigger depression in those who are vulnerable. And by stress experiences, I mean things that happen to people, bad things that happen in their environments, perceptions of stress, people's interpretations and evaluations of stress and the consequences, and maladaptive coping with stress. And I want to emphasize throughout that my general approach takes a bidirectional perspective, the idea of bidirectional relationships between the biological factors, the neural and biochemical, neurobiological, neuroendocrine factors, and genetic aspects of stress, which are the mechanisms by which stress operates. But the environmental factors are what affect how these neural and biological and genetic processes become maladaptive or react in a maladaptive way to lead to depression. I'm going to give you a kind of a thumbnail sketch of several findings from several different projects that we've done over the years about depression, among many. And these are all longitudinal studies, as most of my research has been. Initially, some years ago in the 80s, we did one of the first comparative studies of children of depressed mothers compared to children of mothers who had bipolar disorder or medical disorders or who had well mothers. And this was a 3-year follow-up of the children. These were 8 to 16-year-olds. From that project, I got interested in the question of, well, how do these young mothers become depressed women who have children? What are the earlier origins of depression that lead to depressed mothers? And so I studied high school women in their senior year of high school, followed into early adulthood for 5 years, the antecedents of depression. And More recently, Carolyn alluded to my study in Australia with our colleagues in Queensland, which is a very large-scale study of depressed and never depressed women in the community and their kids. And we were able to come into this ongoing study when the kids were 15, and then again at age 20, and then a bit of a follow-up for genetic purposes at age 25. And then the original investigators continued their birth cohort study with questionnaires at age 30. And we also have data from the earliest years of when the mother was first pregnant and so forth. Now, my work has all included the assessment of stress. And stress, the way it's studied, the way it's measured, and the way it's operationalized is terribly important. It used to be that most research showing that depression was triggered by stress focused on acute stress, that is, acute life events, negative life events. But I and others argue that we needed also to look at chronic stress, that is, what's going on in the people's lives that's there, even if you're not measuring it. The ongoing difficulties in their daily functioning, in their typical roles, such as marital, parenting, financial work, and so forth. And then in addition, more recently, a number of us have become interested in childhood adversity. And this is measured in many, many different ways and for different ages, but it usually refers to abuse, maltreatment, what's been loosely called maladaptive family functioning. And for example, recently people have shown that the childhood adversity effects are very potent for development. Developmental effects, neuro and behavioral emotion regulation issues for kids who are exposed to high levels of early adverse conditions, and that it often sensitizes kids so that later, and I'll talk about this more later, it seems to lower the threshold for the level of stress which is sufficient to trigger depression. And I've developed an interview procedure for measuring all of these over time. And I think that one of the ironies of such an interest across the field in stress research is, although people subscribe to a diathesis-stress model in general, most of them don't actually measure stress. It's implicit. And when they do measure it, they often measure it poorly, using questionnaires and checklists, which are extremely ambiguous with respect to what it really means to that individual person, and also fails to give us an objective index of the severity of the event, except as defined as perceived stress by the person whose mood state will undoubtedly affect that perception. So the ideal approach to the assessment of stress, in my view, is an interview with trained interviewers who are able to obtain contextual information that's sufficient to give a picture of how an event has an impact in the world of that person. And the objective ratings of severity can be measured by independent judges. So that's my pitch for a good measurement of stress. So I'm going to basically be elaborating on several issues in the stress-depression relationship. As I said, a key question is when someone has a stressful experience, why do some people get depressed and others do not? And the why question is the vulnerability. And then I'm going to talk about stress generation, stress continuity, and stress sensitivity, which I'll define in a moment. First of all, just the basic relationship between stress and depression. The black bars show that that a very high percentage of people who develop caseness or diagnosis of depression had a prior severe stress. And the people in the light bars did not become depressed and did not have stress. So this is just the basic finding that the vast majority of people who have a major depressive episode or the equivalent have a major stress that has a triggering effect. We've also shown the same kind of pattern in depressed women and also in their children at risk. More stress, more likelihood of depression. The trouble is with a diathesis-stress approach is that the direction is unidirectional. The stress predicts the depression. Also, it's not only unidirectional, but it is static, and it has always implicitly assumed that the relationship between stress and depression is invariable over the course of illness, over time. But in fact, what we need is models that characterize a bidirectional relationship between stress and depression, and which also show that the nature of the relationship can change over time or because of certain kinds of experiences. So I'll start with the idea of stress generation, and this came to me from doing a lot of interviews with people over time in longitudinal studies. And what I proposed is that the history of having had depression predicts that a person will actually have more events to which they have at least partly contributed. And typical examples would be conflicts with other people, breakups, and particularly events with interpersonal content. And we tested that empirically in our high-risk study back in the late 80s and found a pattern, which I'll show you in a moment, which has been widely replicated now in adults and children and adolescents, especially in women. It's been more studied in women, although it appears to apply to men too, but more reliably and robustly to women. And not surprisingly, it predicts recurrent depression, a cycle of stress, depression, stress, and depression. This was the original study where we showed the pattern that unipolar depressed women had substantially higher rates of interpersonal events that judges determined had been caused, at least in part, by what they did, what their characteristics were, compared to bipolar women, medically ill women, and control women. And so a number of studies have replicated that, as I said, and some maybe 10 years ago, I got interested in applying this idea of stress generation a little bit more broadly. And I call this the tendency of depressed people to create or select into stressful situations that have a long-term potential for further stress. Now, let me show you a few examples which we have shown primarily in our studies in the Australia high-risk program. Domestic violence in teenagers. We studied teens at both 15 and 20, and at 20 we asked them about difficulties in their relationships involving evidence of severe interpersonal violence. Physical injury, needed medical attention, sought police involvement. In fact, what got me interested in this question was the death of one of our participants in our study who'd been killed by a teenage girl who'd been killed by her boyfriend. And what we found was that as we suspected, youth depression before age 15 predicted being a victim of severe intimate partner violence. Also, we found that maternal depression predicted that girls in particular would be perpetrators of violence. And that was especially true for girls who had evidence of poor interpersonal functioning across several roles, close friendship, peer relationships, family relationships, and romantic relationships. So clearly, domestic violence is a problem for kids who've been depressed, and other investigators have also shown similar patterns. Later, we applied that general notion of stress generation to teenage childbearing, because we observed in our sample and decided to test it empirically that among the girls who elected to have babies in their teenage years, many of them had histories of depression. And so we went back and looked at that systematically. And sure enough, the girls who had babies were significantly more likely to have had early onset depression. And they were commonly not married, had not finished high school level education, were not self-supporting. They also were very much more likely to be depressed while they were parents of young babies. And furthermore, as reported both by the girls and by their own mothers, they were not doing a very good job. They had deficiencies in their child rearing skills. So clearly that's a further intergenerational transmission of risk about to happen. In other problematic ways, depressed young people seem to function more poorly in their close relationships. One of my students, Shana Katz, showed that maternal depression predicted that kids, their offspring who were depressed by age 15, would go on to have committed relationships that were more negative, reported as less satisfying, more marital dissatisfaction at age 20, and their partners reported the same thing. So a link between maternal depression, youth depression by age 15, and later romantic relationship dissatisfaction in their close relationships, which incidentally, Shana also showed, went on to predict youth depression after age 20. Similarly, Liz Raposa did a dissertation on close friends of youth who'd been depressed by age 15 and found that they had selected into close friendships. Their best friends were more likely to have psychopathology than were the friends of never depressed youth. And in turn, those young people went on to be depressed in their early 20s as well. So clearly, this expanded form of stress generation can be something that leads to ongoing difficulties and acute stressors over time, portending further depression. So the corollaries of stress generation are pretty important in my view. One of them is stress continuity, and I'm going to illustrate all of these points in just a moment. Continuing stress, lifetime stress. Chronic or recurrent depression, that would be the prediction. More stress, more depression. Not only that, but stress generation means that the individual's depression and stress is very likely to have a negative impact on other people, on their spouses and their children and others in their worlds. I want to mention in passing, too, that we asked the question, is depression the only syndrome that leads to stress generation? And the answer is no. No, definitely not. However, what we found was using complex latent variable modeling, that if you can control for the variance associated with comorbidities and other problems predicting stress generation, you can control for both the broad general factors of internalizing and externalizing psychopathology, as well as control for each individual diagnosis in this large group of individuals. And only major depression had a significant residual predictive effect on the occurrence of interpersonal life events. So in that respect, we can say, yes, there really is something unique about major depression in terms of generating stressful life events with interpersonal content. So let me go ahead and elaborate on some of these points. Stress continuity. This is kind of a no-brainer, but nobody had ever really demonstrated this because of lack of long-term longitudinal studies. So essentially, we tested all of these models. We looked at mother characteristics, whether the mother had significant adverse conditions in the first 5 years of the child's life from pregnancy, whether the mother had depression in her early life, in the child's early life. We looked at youth characteristics at age 15 and again at age 20. And in complex statistical modeling, we showed indeed that stress is continuous over time for these young people, from stress exposure in early childhood to age 5, all the way to age 20. Maternal depression clearly predicts recurrent youth depression and all of the cross-cutting relationships that you would expect of depression, or rather stress leading to depression, but also the stress generation piece of depression leading to stress. This next slide shows that model when tested, but it's not really large enough to read. But this is a graphic of what we did most recently when we were able to obtain questionnaire data, only questionnaire data on the youth at age 30. And essentially what we found is that stress is continuous for people who had high stress, particularly since in the first 5 years of age, continuous stress and continuous depression, and the cross connections between stress and depression, depression and stress. We identified a group of what we called ultra high-risk youth. And this really is what it might sound like. It is a group of people who had a depressed mother, early exposure to stress by age 5, early onset of depression before age 15, and recurrent depression by age 20, and interpersonal difficulties, evidence of clear interpersonal maladaptive functioning by age 15, and probably we have some evidence that it starts very young in the first few years of life, maladaptive interpersonal functioning. But these people are the ones that we can predict with considerable confidence will go on to have lifetimes of stress and depression, and probably intergenerational transmission of depression and other kinds of pathology. Okay, enough of stress generation for the moment. Stress sensitivity. Basically, the missing word in that sentence I later discovered was cause or result in. But it means that the relationship between stress and depression may change, may alter over time, as modified by stress exposure or by personal attributes of the person. Things that modify the threshold at which someone will become depressed in the face of stress. And there are a number of possibilities that cause stress sensitivity. We showed, for example, that exposure to childhood adversity from our early high school study, we showed that it takes less stress to trigger a depressive reaction in the transition to adulthood if you've had early stress exposure in childhood. And others, and we have also shown kindling effects, like Bob Post talked about. The effects of more episodes or more prior stressors seems to predict depression in the face of less stress over time. Definitely a tendency to lower the threshold at which something can trigger a depressive reaction. And there are a number of other factors that seem to affect sensitivity to stress. Some of these are innate. Being female, to some extent, seems to be a sensitizer to the effects of stress. There are some genetic factors that we've studied, and I'm really not going to take the time to talk about those today. Several of the, or at least not directly, but several gene-environment interactions do seem to suggest that people who are, some people are more susceptible genetically. Cognitive styles, we and others have shown certain types of cognitive predispositions that seem to lead them to become more depressed in the face of stress, or more likely to be depressed after lower levels of stress. And these patterns that I've talked about kind of have a theme. And for the last part of my talk before I wrap up, I want to just give you a little bit of an overview, a little bit of a slideshow from various studies that pick out some of the interpersonal aspects of depression in relation to stress. And these add up to paint a kind of a picture, which I think you'll see. First of all, think about the life of a person who becomes depressed. What's it like? What is the social context of the life of a person who becomes depressed later, or has evidence of risk for depression? Clearly, social factors trigger depression. In general, interpersonal factors are more powerful predictors, or interpersonal stressors are more powerful predictors of depression than non-interpersonal stress. That's true for most people, but not all. Some people are highly susceptible to other kinds of stressors. But many people find that negative life events about their close relationships are very powerful. Women may be particularly reactive and vulnerable, if you want to think of it that way, to changes in their social ties. Women are socialized. Some of the differences may be in part biological, but women would be considered to be more susceptible to interpersonal disruptions of bonds. Having a risk for depression is generally conceived of as including learning experiences about social functioning that have been maladaptive. In order to learn how to be effective in your social world, you have to have good role models. You have to learn by observation. You have to have healthy, positive reinforcement and effective negative reinforcers. So the social learning perspective certainly suggests that people who are not functioning well socially probably have been exposed to dysfunctional role models. Maladaptive learning experiences in one's own childhood are very likely to play out in how you interact with your own children. So that's one mechanism of intergenerational transmission of depression. And of course, we do acknowledge that there are a number of traits and behaviors and dispositions that affect social behaviors, that even affect who you select as a mate and so forth. So there are lots of ways which we could be studying the development of effective social skills, or the flip side, maladaptive social behaviors and skills. So just as I said, a little bit of a slideshow through a variety of our findings. In this study of 15-year-olds, we show very clearly something we've seen a lot, which is that girls, that's the yellow, are far more likely to get depressed, higher levels of depression, under high interpersonal stress compared to boys. You can see that under high interpersonal stress, the same high interpersonal stress levels, boys are not getting depressed, but girls are. And so that's a pretty common example of suggesting women's vulnerability to issues, negative events in their social bonds. This slide illustrates a study with my colleague George Slavich at UCLA. George invented the idea that there are particular kinds of interpersonal events that are even more stressful, more likely to trigger depression. And he called these targeted rejection events. It means you get rejected because of something about you. And the most typical example of that would be getting dumped in a romantic relationship, a non-mutual breakup. Another form would be getting fired for cause. The boss says, you're just not good enough. These kinds of events, we went back through our Australia study at age 20. I think we looked at this at both age 15 and age 20. But essentially, what we found is that targeted rejection events do indeed show a greater likelihood of triggering depression, but that it was modified by a gene in the endogenous opioid system. As you know, social neuroscientists have found that that there are circuits in the brain that serve the that are thought to be pain receptors, but that they are very reactive, not just to physical pain, but to social pain as well. And George extended this idea to the notion that certain kinds of candidate genes that serve the opioid system would be protective against pain, if you want to think of it that way, or would leave the person at risk for more social pain. And in this case, it's the people with the G allele of the OPRM1 genotype that is especially susceptible to being rejected with a much higher rate of depression. Another aspect of interpersonal functioning in depressed people is that it appears to be stable. It is not just state dependent. We illustrate this from just one example, and I have many forms of social behavior where this shows up, but we had a chance to collect data from women, depressed and non-depressed women and their husbands, reporting on level of marital satisfaction. And as you can see that the never depressed couples had higher marital satisfaction, whereas the ones who were currently depressed, and particularly the husbands of currently depressed women, reported less marital satisfaction. But the people who were not currently depressed but had a past history of depression were still significantly less happy in their marriages, less happy with their marital satisfaction. So it appears that whatever interpersonal difficulties are going on with depressed people, while it may obviously be exacerbated by symptomatology, it may also reflect some kinds of enduring characteristics that are problematic. We looked into people's close relationships to find more information about the quality of romantic relationships, let's say. These are in high school students and young adults, followed up over the 5-year period. The total amount of depression during the 5-year period was correlated with reports of romantic functioning, as reported by both the girl and her steady boyfriend. And as you can see, the girl's satisfaction level wasn't much affected by her own depression, but the boyfriend's satisfaction, he was very much more dissatisfied in cases where the girl had had a longer period of depression over those years. There's also a link between negative, shall we call, conflict resolution in terms of both psychological, coercive techniques that they were reporting, as well as physical techniques that these young couples were reporting. Much worse coercive tactics because of higher amounts of depression over time. My student, Nicole Eberhardt, and I were interested in the question, well, in stress generation, what are people doing in their relationships? On a daily basis, what does stress generation look like? Can we detect it in the daily operations of interactions between couples? So she recruited 100 UCLA couples in committed relationships, and she studied the women, and she excluded all women who were currently depressed. So these are non-depressed women. And Nicole hypothesized that there are several, shall we say, interpersonal styles that the literature has linked to depression. One of them would be excess reassurance seeking. People who constantly ask for reassurance and support are kind of a pain, and they often get rejected because they are annoying to their mates. She also looked at insecure attachment representations, people's fears of abandonment, their insecurity about rejection and so forth. And she developed a questionnaire that could be administered on a daily basis in a daily diary study that gives concrete examples of what those behaviors might look like. And she asked them every day at a certain time in the evening to indicate which of those had happened. And every day she also asked what events, if any, occurred that represented conflict in the relationship. And then she collected the daily diary information for 2 weeks. And then at the end of a month, she also assessed depression and also an interview about the stressors that had been reported to occur to see if any of them reached a certain magnitude of severity. And what she found was that interpersonal style, that is the daily examples of insecure attachment and reassurance seeking, predicted daily conflict stress in the romantic relationship and higher levels of depression at the end of 4 weeks, controlling for initial levels of symptoms. And she also found that these patterns of daily little micro-stressors were much more likely to precipitate major stressors over this 1 month period. In other words, true stress generation. So it seems that we can understand some of what goes on that might be a contributing factor to the difficulties in romantic relationships as they play out on a daily basis. Clinicians, take note. Nowhere is the interpersonal impact of depression more negative than the effects on children. Depression runs in families, as is well established, but the kids are inheriting not only genetic predispositions, but they're also inheriting a cluster of negative circumstances that are largely interpersonal. And so just at the descriptive level, I went back into our Australia study and looked at interviews with women about the conditions in their lives and data that we had collected from them. And unfortunately, I don't know if this is as legible as I would like it to be. Comparing the women with histories of depression with the women in that sample who had never had depression, the depressed mothers had a number of adverse conditions that were basically interpersonal in nature. She was less likely to be married to the child's father, lower marital satisfaction, poorer quality of relationship with the kid, more acute total stress in the past year, including more interpersonal stressors, higher levels of chronic stress, higher rates of depression in her own parents, which often is likely to accompany parenting difficulties. Higher rates of diagnosis in her own husband, the kind of assortative mating phenomenon, and higher rates of either being abusive herself or have been abused as a child or in a relationship with severe domestic violence. So this is what the offspring get. They get this constellation of maladaptive family factors that contribute, I think, substantially to the risk for developing disorders. Most people who study this topic agree that probably the key ingredient is quality of parenting. People who are miserable can't function very well, that's a given. But even when people want to function well, want to be good parents, they often have dysfunctional styles, and they often find it very difficult to perform in the parenting role in a supportive and warm way. They are often harsh, rejecting, critical. They often are withdrawn or disengaged, or they're both of those, harsh and disengaged. Or others have described patterns of high control coupled with low affection, called affectionless control. So these are very common patterns. They're observed if you look at the mother-child dyads in the laboratory. Adult depressed patients report these characteristics, report these patterns. Children who are attending clinics for depression report these kinds of patterns as well. So this is a very robust carrier of the negative effect of depression on children. And therefore, it doesn't come as a surprise that in our Australia study, there were 814 families that we studied. High rates of depression and anxiety and other disorders as well. Low self-esteem in the kids, insecure attachments. Whatever we measured looked worse in the offspring of depressed mothers. We also found the patterns, and I've shown you a little bit about the stressful, difficult relationships that kids are having, even by age 15. Problems in their relationships with close friends, peers, family members, and their own romantic partners. And of course, this portends romantic relationship discord, which is very depressing. Portends abuse, dysfunctional parenting, low social support, and recurrence of depression, etc. So the constellation of ingredients that are contributed in the families of depressed parents are then the legacy that person brings to their own next generation. So in conclusion, there is a conclusion. These are just some thoughts about where we are now. And you can deduce from these where you think the field ought to put its efforts. So I think it's safe to say that some of the issues that we've had for 40 years remain the same. In challenges about treatment, challenges about diagnosis, research design, and the like. It's clear that depression and stress go together. Not for everyone, but for most people who get depressed, stress is part of the picture. But it's a bi-directional relationship of stress and depression cycling through probably for a lifetime without very effective treatment. But stress not only affects the individual's behavior, but environmental stress, as we're learning from developmental neurobiology and developmental psychopathology, environmental stress sculpts the brain in childhood and affects neurobiological mechanisms that are associated with stress reactions. And this is obviously a topic of considerable interest. Environmental stress may occur in cases where people are ill-equipped to deal with stress, but it may simply also overwhelm their adaptive capacities. And overwhelming stress promotes maladaptive social functioning. Depression largely affects women in their childbearing years. Clearly, there are a number of correlated risk factors, as I've elaborated, and the offspring themselves are at high risk for further intergenerational transmission because of acquired patterns of maladaptive problem solving and other interpersonal psychopathology. I think that depression in teenagers is particularly problematic with high levels of risk factors that are quite identifiable early on and portends recurring depression and recurring all sorts of other negative impacts on people around them. I've said that I think it's urgent to particularly identify ultra high-risk teens, and we know who they are, but they are the ones who are going to be at greatest risk. I think that a number of the risk factors are probably not modifiable by the time they have done their damage, but some of the genetic and neural mechanisms, which are mechanisms and moderators of stress responses, are potentially modifiable and should be modified where we can for both, obviously, developmental and mental health reasons, but, well, for physical health reasons, as I'm sure most of you know. Unfortunately, we need to have the kinds of research designs that are extremely complex and expensive because they need to be longitudinal, but they need to include multiple levels of analysis. Everybody says this, it's very difficult to execute this, but more and more I see complex biological genetic designs, but I'd increasingly like to see more attention to the environmental factors and good assessment of stress. I'll just end by saying intervention implications seem clear, but they're very daunting. Changing family systems, changing habits possibly acquired since childhood, helping people to deal with difficult environmental experiences and conditions, but at a policy and community level, modify as many of these negative environmental conditions as we can. So clearly there needs to be a top-to-bottom approach to really deal with some of the problems that we have. But as clinicians, I think the thing that we can do is to try to understand one basic thing, that when a parent is depressed, when you're treating a depressed adult, there's really the family to consider. It really has to be viewed as a family problem, and agencies need to be set up to deal with entire families. We need to mark our effectiveness of treatment, not just in terms of symptom reduction. I think there are a lot of other variables that are exceedingly important that we ought to try to modify, whether it's better ways of dealing with stress, better interpersonal problem solving, better functioning in most important social roles. Clearly, the kinds of interventions that are needed, but which will challenge us for a long time to come, are more than treatable by simply medication alone, simply by cognitive restructuring alone. So I think we have a lot to do, and hope I'll be around for some of it to see it happen. Thank you. Just acknowledge my colleagues, particularly on the Australia project, Patty Brennan and Jake Najman, and grant support. And I've tried throughout the talk to acknowledge as many of my graduate student collaborators as I could. So.